The patient is a 60-year-old shopkeeper of a furniture store. She has high cholesterol and is on cholesterol medication, Lipitor, otherwise has a clear medical history. She has had a fair amount of dentistry done 10 years ago but have not seen a dentist since. Her main concern is the food impaction in all interproximal regions of her restored teeth. The teeth are also very sensitive to cold and sweet juices. The patient wakes up with tender teeth and neck aches and headaches often. She described this moment not satisfied with the color of her crowns after observing her neighbor's recent dental work. Examination shows that there were multiple crowns done on teeth 16, 15, 14, 24, 25, 26, 27, 36, 35, 45, and 46. 36 was endodontically treated after the crowns were issued. There is also multiple restorations and she has rather fair periodontal hygiene. However, the interdental space bleed often when flossing around the crowns. The crowns possess ill-fitting margins, overhangs, and there are leaky restorations at the adjacent sides. There is group function on lateral excursions with sheared ceramics from crowns with possible previous deflective contacts. There is right-clicking on the TMJ, on opening and closing, and some soreness on the masseter muscles. Here, a diagnostic mock-up has been done on the right side, where the provisionals will be made. Discussion of treatment options were made, and it's all in the clinical write-up. Here, the comprehensive treatment plan will involve the removal and exploration of the old crowns, caries control, provisionalization of crowns with single temporary crowns, and issuing of the definitive crowns. Caries control was observed and the defective restorations were removed and caries lesions were restored with glass ionomer cement. Individual provisional crowns are then made. 5 crowns were made, 3 at the top and 2 at the bottom of the right side. The material of choice is bis-acrylic composite, where it is expressed through the silicone putty made to set. It is then removed, separated, trimmed, polished, and stained. The patient's aesthetic requirements and demands were quite high, and the provisional crown that was fabricated was made to mimic the natural teeth as much as possible. But what is more important is that when the provisionals were issued and cemented and tidied up, the occlusion of the patient was evaluated and checked. Adjustments were made to suit the patient's envelope of function. The patient is then allowed to wear the provisionals for a period of time, in this case 1 month. The temporary cement used was zinc oxide eugenol based, IRM, and feedback was reported by the patient. The hypersensitivity was lost and the patient reported of a more comfortable bite with better freedom of movements. Once the cuspal anatomy and inclinations were finalized, alginate copies of the provisionals in the mouth were obtained. This is to instruct the dental technician and ceramist to duplicate its exact anatomy into the definitive restorations. Margins of the provisionals were also made equi or slightly supragingival to allow resolution of gingival inflammation around the crown sites. Once patient satisfaction has been achieved, crown preparation and impression protocols were then performed. Index putties based on the duplicated provisional in-mouth study models were used as an index reference. It was then observed that the abutment teeth were under-prepped and adequate reduction was made. Occlusal reduction was kept at a minimum as there was already 1.5 to 2 millimeters of restorative space per tooth. The main focus was the deep chamfering of the margins to provide intimate adaptation of the new definitive crowns. We were unable to complete the caries control and restorations on the carious teeth as there was a blackout in the office and the surgery was running on emergency power supply. Double retraction cord technique was used and the margins were further fine-tuned with that. And finally, a two-stage injection molding impression technique was implemented. A heavy body impression was taken, its associated space cut out to accommodate the second light body addition silicone impression material, where it is expressed via a hole made into the special tray. This was then repeated on the opposing side. Residual retraction cord attached to the impression was left behind to minimize distortion of the impression material. The shade guide was obtained where A2 Vita Classic was the mutual agreement by the clinician and the patient. Provisionals were then cemented back in and the lab form was written. The return definitive restorations are in the form of monolithic zirconia crowns. The material of choice were made so for its aesthetic requirements and strength, where it could tolerate 1,400 to 1,600 millipascals of stress. The patient then returns to have the definitive crown cemented where the provisionals were removed, and 2% chlorhexidine and pumice slurry was used to wash off residual temporary cement on the abutment teeth. This is also used to improve bond strength of the definitive resin cement. We also take the opportunity to restore the remaining unrestored teeth. This was achieved by using glass ionomer cement and the coping of the provisional crowns, which were layered with a layer of Vaseline so that we can attain good adaptation of the restorative material without affecting the cementation of the definitive crowns. The full ceramic crowns were then tried in. As you can see that there is adequate passive fit, and then silane has been added to the surface of the crowns where it is to be bonded and dried. It is then cemented one by one with resin cement, left to cure, and flossed and tidied up. The occlusion has then been inspected and virtually no modification or alteration of the definitive crowns were made. The patient is very happy with the general outcome and suddenly voiced out her concern to restore the 4-4, which was not touched at all during the procedure, as she has noticed that the dark stained restoration was much more noticeable. The patient has also made a decision to do the restoration of new crowns on the left side sometime next year when her budget is much more favorable. A 2-month recall has been made later, and the final picture shows the appearance of the crowns on the right side.